Good evening, everyone. We appreciate you taking time out tonight to join us. We are doing our CME this evening on sports participation and the pre-participation physical evaluation. I'm Patty Kilburn. I'm one of the physician liaisons at Seattle Children's. And before we start, I just wanted to mention that we have two speakers tonight, and they will each be monitoring each other's chats. So feel free to place a chat in the chat box when you have them, and then we'll answer those accordingly. And then, of course, at the end, I know they would love to take your questions, and so please feel free to stay and ask some more questions at the end. I will also be throwing an evaluation in the chat box towards the end, so we would love to hear your input. So I will go ahead and start introducing both of our speakers. Dr. Meg Vernon is an associate professor of pediatrics within the Seattle Children's Heart Center. She's entering her 18th year in the program. She maintains a large general cardiology practice at Seattle Children's Bellevue Clinic and also serves as a preceptor in the Fellows Clinic on the main campus. In addition to her work in general cardiology, she is a medical director of the Exercise Lab. Dr. Vernon is especially passionate about promoting physical activity and sports participation, with a particular love for outdoor activities. Outside of her clinical work, she and her husband enjoy hiking and skiing with their 3 children, as well as cheering them on from the sidelines and riverbanks as they pursue their own athletic endeavors. And Dr. Jack Salerno is a professor of pediatrics and serves as the vice chair of clinical affairs for the University of Washington Department of Pediatrics, and has expertise in sports cardiology and heart rhythm disorders. He has a research interest in preventing sudden cardiac arrest in athletes, and more specifically, how to get athletes with electrical heart disease back in the game. If there is a ball involved, he is interested. He has 3 children of all who have participated in competitive athletics, and yes, they have undergone cardiac screening, including the ECG and the echocardiogram. He has over 30 publications related to sports and has participated in several policy statements on sports cardiology, including the American College of Cardiology, Heart Rhythm Society, and the American Academy of Pediatrics. He is a board member of the Nick of Time Foundation and has participated in almost 75 sports screening events. He also participates in the Washington Interscholastic Athletics Associations on their sports advisory board. So with that, I will let Dr. Vernon begin her presentation.
Thank you, Patty. So again, we're going to talk about sports participation and the PPE. Thank you very much for joining us. So no disclosures tonight. You've heard about Jack's activities. So learning objectives for this evening is to increase your confidence in evaluating athletes and determining medical eligibility. We're going to review the PPE with a focus on cardiovascular symptoms and family history, and then discuss sudden cardiac arrest from a multifaceted public health standpoint. So an overview of how we're going to meet those objectives. I'm going to talk about the PPE, a little bit about historical background, the current PPE, sudden cardiac arrest, and the controversies around the PPE. Then I'll hand off to Jack, and he's going to talk about secondary prevention. And then it really is my honor to have you and me be able to ask an expert with Jack being here tonight. So let's talk about the PPE. This is really, it's been around for decades. The original task force was formed in the 1990s, so before some of you were born. The first statement came out in 1992. It's a collaborative working group with members from the American Academy of Family Practice, Pediatrics, and Sports Medicine. The overarching goal of the PPE is to promote the health and safety of our young athletes that are participating in training and competition, and also to identify those who may need additional evaluation before participation, or very rarely exclusion from sports participation. So again, the overall goal was to standardize youth sports physicals that were required before participation. So what are the components of the PPE. So all student athletes should have a detailed family and personal history, as well as physical exam prior to participation in high school sponsored sports. But I would also say that we would encourage that before club sport participation. Recently, so we're on to the fifth evaluation or the fifth edition of the PPE. And there's been a couple important evolutions as the new editions have come out. So screening should now be incorporated with the well child check with the primary care physician. The reason for that is the hope is that the primary care provider has an established relationship with the child and hopefully their family, and has some extra knowledge of the athlete's personal and family history. And this is a comprehensive screen. So I think that the questions that come up the most frequently, at least definitely the ones we hear about, are those that are related to the cardiovascular system. But the PPE is a comprehensive screen, which includes concussion and injury history, anxiety and depression questions, because sports participation can exacerbate both of those, questions about substance abuse, and importantly, the female athletic triad. But as I mentioned, the questions which receive the most attention are those that are related to the cardiovascular system. And I think that there is a very valid reason for that. In the last 5 years, we can all, or many of us probably witnessed live on TV, Christian Eriksen going down during a soccer match, and then Damar Hamlin going down, both of them from sudden cardiac arrest while playing sports. So these events that have been going on that once caused nighttime evening news coverage or potentially the weekend paper edition now are now witnessed by national and international audience, and then cause really social media wildfires. So social media has not only increased in awareness, but it also has brought some anxiety related to sudden cardiac arrest. With that in the background and understanding why the cardiovascular questions come up and cause so much angst for us providers, let's talk a little bit about sudden cardiac arrest and what causes it in young athletes. There's two general categories: autopsy negative and structural abnormalities. So autopsy negative are really, are primarily things that are non-structural and mostly involve the electrical system of the heart. So long QT syndrome, CPVT, which is catecholaminergic polyventricular or polymorphic ventricular tachycardia, and Brugada syndrome, as well as commotio cordis. And then structural, the other category, are heart muscle diseases, the most common there being hypertrophic cardiomyopathy, and then coronary anomalies. Those are the vast majority of those are coronary artery anomalies where the right or left coronary artery is coming off the opposite location off of the aorta that it should. Myocarditis, and then congenital heart disease, specifically aortic stenosis when talking about sudden cardiac arrest. So overall, what I just said there is that there's lots of causes. There's not a single cause of sudden cardiac arrest. There's multiple causes of cardiac arrest. What about the incidence of sudden cardiac arrest? Well, there have been many, many attempts at nailing down and identifying, as screening has evolved, the overall incidence and decreasing the incidence of sudden cardiac arrest. Well, where are we at? So one of my kind of most favorite papers, and also a recent publication, so this one is from 2024, just January of 2024, so about a year ago, looked at NCAA athletes. So these were Division 1, 2, and 3 college athletes in the United States from the 20-year time period, 2002 to 2022. And it looked at causes of death of those athletes. They ended up with an overall incidence of about 1 in 100,000 athlete years. And if you look at the causes of death during that time range of any athletes, you'll see that accidents were about 50%. That's the blue. And then cardiac deaths were about 13%. Suicide and homicide were both in kind of the 9 to 10% range. So sudden cardiac arrest was around 13%. The incidence being about 1 in 100,000. You can see the range slowly has come down during that time period from 2002 to 2022, with a range of 0.33 to 4 per 100,000 athlete years. This brings us, so these last 3 slides bring us to the challenges of sudden cardiac arrest screening. There are multiple causes, and incidence overall is low. The other important thing that I alluded to by talking about a study that looked at NCAA athletes over the 20-year period, 2002 to 2022, is that those athletes were all screened. They were all screened over their career of participation, and still there was an incidence of sudden cardiac arrest. So cardiac arrest, importantly, can be the first manifestation of an underlying abnormality. There were many, many screen negatives in there. So let's go back. With that, let's go back and talk about that PPE and specifically those angst-causing heart health questions and the examination, the cardiac examination. So if we look at the heart health questions about you, they're divided into 2 categories: heart health questions about you and heart health questions about your family. So the first one for heart health questions about you is, have you ever passed out or nearly passed out during or after exercise? And I think it's important, from a cardiologist, I think about that slightly differently. It's a sudden collapse without warning versus, have you ever developed pre-syncopal signs or symptoms during recovery following exercise? I think we see this a lot, where you'll have, like, one of the most common ones I get is that you have a cross-country runner, they've gone their three miles, they make it through to the finish line, and then they've really pushed at the end, and then they stop completely, and it's really hot, and again they stopped completely, and they slowly get tunnel vision, and they start feeling not great. They have no palpitations, and they've just gone in a very vasodilated situation to their body is doing everything it can to compensate and keep them upright. So that's very, very different than a sudden collapse without warning while somebody is participating in exercise. Moving on to question number 5 there. Have you ever had discomfort, so chest discomfort, pain, tightness, or pressure in your chest, importantly during exercise? So that during exercise, that differentiation between chest pain when you're sitting on the couch versus chest pain when you're on the basketball court is very important. Does your heart ever race, flutter in your chest, or skip beats? Again, this is during exercise. I think the vast majority of us can think of a time when we've had a hiccup beat or noticed our heart, is the way I usually think about it. And that's very different than when you're exercising and you're noticing that you have either your heart is suddenly racing while you're exercising, or it feels like it's having those skip beats during exercise. Then has a doctor ever told you that I have heart problems? Or has a doctor ever requested an ECG or an echo for you? I think those are a little bit more self-explanatory. And then this last, or number 9 here, do you get lightheaded or feel shorter of breath than your friends during exercise? I think the key there is it should actually be kind of during your friends of a similar physical fitness level. So we get this frequently, kids referred to us for shortness of breath that have never played soccer before, and then they just suddenly decide in 7th grade that they want to try out for the soccer team. So there's an importance of peer comparison that are of the same physical fitness level than yourself. And then finally, have you ever had a seizure? That's really because seizures can be confused for heart rhythm disturbances. So we like to hear more about if you have a seizure history. Things about your family. The questions we see over here, has a family member or a relative had heart problems or an unexpected sudden death before age 35? So I always ask here when I meet kids in clinic, or the example I give is the one that's included on the PPE, which is there a family history of drowning in someone who knows how to swim? And then unexplained car crashes. And then finally, importantly, does anyone in your family have a genetic heart problem? So this is something that's been diagnosed. Do you have a family history of Marfan syndrome, hypertrophic cardiomyopathy, anything that carries a diagnosis that is associated with sudden cardiac arrest or sudden cardiac death? And then finally, pacemakers and ICDs. The key there is not in grandma when she's 85 years old, but when someone who's young. We want to know about people that have had problems with their heart before the age of 35. Then on examination, there's an important thing that comes up on exam from a general cardiology standpoint. If you see, there is an asterisk after the heart assessment. So everybody, murmur, fine. That's a new murmur. That's a good reason to refer to us. But I'd like to take a couple slides and talk about the statement that says, consider ECG, echo, and referral to a cardiologist for an abnormal history, exam findings, or a combination. I think it's really important to know and understand the tests that you are considering there. So ECG and echo. So why add a 12 lead? Jack's going to talk a little bit about universal screening, but I think what we know about universal screening is that it has consistently been shown to increase detection. So these are the autopsy negative electrical events. So long QT syndrome, Brugada syndrome, Wolff-Parkinson-White, so WPW, and then hypertrophic cardiomyopathies. Those show up on electrocardiograms. So a 12 lead ECG is great at identifying those abnormalities. However, an ECG screening, specifically just a standard universal screening, they have a high false positive rate. And that can be up to about 15%. And importantly, that's with conventional criteria. There are sports specific criteria that are a little bit different and bring that high false positive rate down. And then importantly, when you do an ECG, there is a whole category of etiologies of sudden cardiac arrest that is missed. And specifically, anomalous origins of the coronary arteries are not picked up on an ECG, nor is catecholaminergic polymorphic ventricular tachycardia, because your baseline ECG when you're resting is normal. And then I want to take a slide to talk about the echocardiogram, because I think it is important that if you're going to order an echocardiogram, that you get the most complete and of the highest quality test when you order it. And an echo is not an echo. There are a variety here. So the important differentiation here is that by adult criteria, so this is the American Society of Echocardiography, there is a pediatric echo and there is an adult echo. And the components of the two studies are slightly different for a complete study, basically because as you age, your acoustic windows, or how we can visualize the heart, deteriorates in time. So when we do a pediatric echo, and if you look at the criteria for a complete pediatric echocardiogram, the coronary artery origins are assessed, and that's considered part of a standard normal complete evaluation. So if you order an echo that's for a murmur using pediatric criteria, we look at the coronary arteries. But if you order an echo that's for a murmur using adult criteria in an adult facility, they don't routinely look at the coronary arteries. And if you go back a couple more slides, or think back to what I said about all the many causes of sudden cardiac arrest, one of the silent ones is anomalous origins of the coronary arteries. So this goes to my kind of, if you're going to obtain an ECG or an echo, make sure that you are getting the best quality study that you can. So then with those kind of two limitations and thoughts on both the ECG and the echocardiogram, let's talk about the PPE, that overall screen, and some of the limitations that are known to the PPE. So we're now on the 5th edition of the PPE. It's been in practice for multiple decades. So we have a lot of data about it, a lot of data on its implementation. Overall, the PPE has excellent intent, but it is limited by low sensitivity. As I mentioned, sudden cardiac arrest still happens. And then on top of that, there's a high false positive with the PPE just in general. There's a question about how frequent should the PPE be, how frequently should you have to update your PPE? In general, it's every 2 years. But as you all probably know, hypertrophic cardiomyopathy tends to can evolve, and it tends to show up first in the teenage years. Then there's a couple of tricky things. Personal history really requires honest reporting by the athlete. They have to sign the PPE and the history, but there's a lot of pressure. And on top of that, these kids want to play. So this is pressure by themselves. So internal pressure, but also there may be pressure from their coaches and their family that they want to play. So whether they honestly fill out their PPE screening questions is always a little bit unknown. And then family history. Family history is frequently incomplete. There can be just genetically incomplete with the increasing use of assisted reproduction over the last few decades, and also when adoption is involved, family history can be incomplete. There have been concerns that have been raised that it can be a potential barrier to participation for both socioeconomically disadvantaged areas as well as more rural areas. And then there's just the how many kids need a PPE. So there's about 42 million kids in the United States, and about half play sports. And we certainly know that that those of us that are providing pediatric care, that pediatric care providers have decreased over the years. And importantly, we also know that there are a lot of people who have started to do more pediatric care. And it's really our responsibility to make sure that we're getting the best positive or the best possible screens, and that we're minimizing our high false positive rates by making sure that our education is the best we can for providers that are providing our pediatric care at this point. So in summary, the PPE is a really, really well-intentioned, I think it's an important comprehensive assessment of our athletes before they participate, but it's definitely imperfect. From a cardiovascular, sudden cardiac arrest standpoint, zero risk is unobtainable. I think the NCAA study showed that nicely. And I think the other thing that's super important is that if we think back to why was the PPE started, it was a goal to standardize sports physicals, but we really want to encourage participation, and it's essential to limit unnecessary restriction. With that in mind, please reach out. We know that sometimes our wait times are long, and I would really encourage you to use eConsult, because those are addressed rapidly, and many of these sports questions we can answer quickly, sometimes just by an email, or then even telemed with there's all sorts of easy ways and fast ways to get your kids in to see us or to ask us a question. I'd like to hand off to Jack, and he is going to talk tonight about secondary prevention, which is a critical component of sudden cardiac arrest screening and decreasing sudden cardiac death rates.
Thank you for being here. I will talk a little bit about the personal history section. I see there's a question in the chat, but I think what I'm going to...
Dr. Salerno, I'm sorry, you're like a little underwater.
That's too bad, because I was not when we did all the testing.
Yes, no, I know.
Is that still bad?
I think it's better. Do you hear it, Dr. Vernon, at all?
Sorry.
You were, I think you got a little better there, Jack.
Yeah. Is it still better, or do I need to leave?
No, just a little underwater. Yeah, if we can't figure it out, I can understand you. So that's the good news. It's just a little.
The option I have, because we tested all this,
yeah,
is to go out and come back in. So let me know. You can pause me if you'd like, but I will I will try to do my best here and act as though I'm not underwater. I guess this is a sports cardiology presentation, so I'll pretend I'm scuba diving as I do so. But when I realized that Dr. Vernon just said that there's really no such
No,
thing
I'm
as zero.
Dr. Salerno. I think we got to test it a little bit.
I will be come back. Breaking up, or that might just be me. Give me one moment. I will be back.
Okay. Okay. Sorry, everyone. I would tell some jokes, but I don't have any. I don't have any. We're taking this brief intermission. Dr. Vernon, can you see the chat?
You know, Patty, I was just looking over there to see, let me just see what I've got here. Okay, so there's, so just to make sure everybody saw it, I'm kind of going in order here. Jack wanted to make sure that everybody is aware that there's a PPE resource online that's free for everybody. And I would agree, it's a fabulous resource that is available free to all providers. The other thing I would mention is that we are very lucky here in Washington State, and that we have Jack's worked really hard with the WIAA, and we have a universal form that is free on the WIAA website. Very easy for you to download. And everyone, I think that was 2017 that they got that through. So that's very nice and free and available to everybody on their website.
And then Megan, am I still underwater? Do you need to?
You're
No,
way
you're
better.
great. You sound
All
great.
right, I don't know if I'm great, but I'm better. Thank you. I apologize. So let's go through. There's no such thing as zero risk, as Dr. Vernon said. So let's talk about what secondary prevention might look like. So we have a few slides here. If you can go to the next one, that'd be great. What I want to talk about is strategies to improve survival after sudden cardiac arrest, because the screening is imperfect, and so we can have kids who have sudden cardiac events. But also importantly, there are parents and grandparents at some of these games that haven't been screened perhaps and are probably at higher risk. So what I want to talk a little bit about is public awareness and advocacy. I'll talk about educational campaigns, policies, and laws, and then just the work that the WIA and then the Nick of Time, who I've volunteered for, as well as professional societies. And the part about professional societies really is a mind shift change. So even if we follow all the rules, sports are still dangerous. So if you read this side, soccer is not allowed. Soccer can only be played in the archery range. I mean, even if you follow those rules, that seems to me that sports could be dangerous. I don't know what it's like to get hit by an arrow or if they're shooting for you, but nonetheless, I think, we can't have zero episodes, so we have to be prepared. So the next slide will just go into some of the things that we've done. And so secondary prevention, as you all know, it really requires high quality CPR. We're in a pretty fortunate state in King County until actually our hospitals got full, because we actually had medics and first responders who could do CPR. So we really had a really fast response time. But as hospitals got full and ambulances also got full, particularly during COVID and with the emergency departments over crammed, if you will, our rate dropped off. And sadly enough, only about 20 to 30% of people who have cardiac arrest have bystander CPR. And it's time is money. The faster that somebody starts CPR and gets an AED, the more likely you are to, one, survive, and then two, survive neurologically intact. And so despite changes, really the annual CPR rate, even with hands only, is only about 4% of the US has been trained in CPR. So the next slide, I believe, goes into legislation. So in 2011, the American Heart Association recommended universal teaching of CPR. Just so you're aware, in 2013, the Washington State legislature passed CPR as a requirement for high school graduation. So in addition to making the lamp that the light turns on and off, you have to learn CPR to graduate. And so I think that's a big deal for our state. The next slide. And this is also where some of your patients may be coming and asking you questions. So we, the Nick of Time, the Sports Medicine Center at the UW, we're part of this Sudden Cardiac Arrest Awareness Act, which passed in 2015. And so as a part of this, we do training for coaches, athletes, and families on symptoms that are concerning for cardiac events. And so this is where the coaches now know that chest pain may be problematic and talk to the family, and then the family may come and talk to you. So there's a lot more awareness sudden cardiac arrest, particularly in the state of Washington. I believe there are maybe some other folks from outside in our WWAMI region, but at least in the state of Washington, we have this awareness. So people are bringing up these questions, and so we obviously need to address them. Next slide. And I'm on the sports advisory committee for the WIA, and as Dr. Vernon mentioned, we actually created a standard single form in 2017, and it's not perfect. I think the questions are sometimes a little confusing, but it does have a resource that provides information for background on the questions. And I would there's a couple of things that I did want to say as it relates to the questions. One of which is syncope or passing out. It seems scary to actually have a syncopal episode during sports, and so you face plant, but 9 times out of 10, it's actually not a cardiac event.
It requires a full evaluation, including an echo and exercise test, but most of the time, even with a face plant during exercise, it's not a cardiovascular etiology. Obviously, they should come see us. The other important one that I think about a lot is chest pain. A kid will report chest pain with exercise. I think chest pain with at rest and exercise is different than chest pain and exercise alone. Because a lot of kids, when I breathe or I say class, it hurts. And so I think those are different, just to be mindful.
Dr.
And I'm sure-
Salerno, I am so
Yes.
sorry. It just happened like 30 seconds ago.
That's awesome.
You're gonna have to like move around your entire room to get like reception, I think. I'm sorry.
It's Springbrook. Yeah, I don't know. I have to leave again. I apologize.
All right.
Last time.
Well, there is a question. I don't know if it got answered. So I'm going to ask Dr. Vernon, you tell me. Okay. So this is from Sean Marie Menziwa. In the personal history
It's a
section.
great question. So in the personal history section, how do you account for a lack of conditioning? Young athletes often click yes on the racing heart symptoms, but upon further discussion, this symptom goes away when they get more used to the newer physical activity. So Sean, I think that is a fabulous, the way I think about the yes and no is I think it's important to see that yes doesn't mean that you can't clear them for sports, because then the yes part says, please explain. So if on further evaluation, you find out that, oh, this is getting better now that they've exercised more and their conditioning is coming better, I think that then you can use your comfort and expertise and the idea of this is conditioning, that the kid is doing better, and then just say, hey, if this changes, come back. But I think that's a great question. We get that preseason, and that's kind of when it goes, my comparison of your symptoms compared to your peers, because we definitely get not only the heart racing, but the out of breath. I'm out of breath, but I've actually never played before. So sometimes they just need some reassurance.
So I think
We're always happy.
I have a timer running before I lose
there he is
again.
He's back.
Am I back?
Great.
All right.
You're
So
back.
I did want to talk about chest pain at rest and exercise being different. And then the family history can really be challenging. And we try to limit it to first degree relatives. My great aunt Sally, that might be important, but I don't know that that's a necessary visit to see the cardiologist. And the other thing too, and what Meg was just talking about is conditioning. I find when kids go from 3rd grade soccer to 4th grade, and as the competition gets higher, that level of competition, then their kids, it becomes obvious who is sort of a more elite athlete and who isn't. And so it's sometimes it's not necessarily a cardiac condition, but it could be just the difference in athletic ability. And then, so lastly, the Sports Advisory Committee, we did sudden cardiac arrest awareness, which is as I was talking about, educational campaigns. I have what we do for emergency action and the pre-contest timeout card. Hopefully I don't time out before I get to do these slides. So let me go to the next slide. I apologize for all the coming and going. So emergency action plan, Meg and I were just actually with the American Heart Association talking about emergency action plans, right? So if a kid collapses, a parent or a grandparent collapses, you want to call EMS with under a minute and then get the on-site AED within 3 minutes. What we found out is certain schools, the AED goes with the trainer. So if the trainer has an away game, guess what? The AED is with that trainer. So if there are other team sports on the campus, there may not be an AED. So anyway, we just were talking to the AHA about safety in schools. And so the important thing here is to actually practice it. I mean, having a policy is great. If nobody knows where the AED is, nobody knows how to get it, and nobody knows how to activate it, then it's not really that helpful. And to that end, the next slide actually shows what the WIA has asked before the game. So this is the official, and both coaches or trainers come and they actually ask, where is the AED? Where's the emergency equipment available? Where are there environmental concerns? And so they do this before every contest, and who will call 911 and who will go get the ambulance. So to the best of our ability, again, there's no way to prevent some of these events from happening, but secondary prevention can be helpful. Next slide. And just, I'm guessing that some of you have seen the Nick of Time Foundation. We've done about 30,000 athletes across the state. And so what happens there, they do get CPR and AED training. That's our commitment to the emergency action plan. They do get an ECG. Meg was mentioning the false positive rate for ECGs. With athlete specific criteria, it's actually down to 1 to 2% false positive. And we're hosting this week the international criteria for sports ECGs, and we'll refine that even further. So again, the ECG is not a requirement. It moved from like don't do to is reasonable in the last 5 to 10 years, suggesting that maybe the ECG does have some power over some of the questions that you're asking. We do have experts asking the same questions you do with the PPE, and then we have an echocardiogram on site. Just for awareness, Meg and I were talking about this. It's really a very limited echo. So we say it looks fine, but it's really a limited ultrasound with portable equipment. So if there are still questions that remain, I think cardiology referral may be reasonable, even if we say normal echo. And I think there may be one more slide. So this is probably the biggest change in the way that we as cardiologists manage cardiovascular disease and return to play. In the past, it was much more paternalistic, where we said, oh, you have a disease, the best thing for you to do is sit on the sideline. And that didn't take into consideration people who, their entire life was as an athlete. That's who they were. That's how they showed up in the world. But it was very easy from a medical legal perspective to say, I'm sorry, you can't play. And so in the last 3 to 5 years, that actually has shifted to what's called shared decision-making, where we talk to the athlete about the risks, about the benefits, and we make a shared decision about return to play, because we recognize there's a possibility for avoiding harm by restriction. So it's a completely different philosophy with shared decision making and return to play. And I was going to put a comment in the chat. The NIL, name, image, and likeness, is changing some of this, where athletes may not want to report, or if they do report symptoms, their families don't endorse them because they actually may be making money for the family. So that's really, and that's mostly in the college level, but I'm curious if that will change in the future. But it does. The point here is really shared decision making is getting the athlete back into the game, and this is probably an opportunity to sort of prompt that we are going to start a sports cardiology clinic, and what we're hoping to start with is kids who are in season, meaning they're a wrestler and they're wrestling right now, because what Meg and I and others have seen is these poor kids wait to see you all, then they wait to see us, and then the season's over. And that's a big deal for some of these kids. So we're trying to start a sports cardiology clinic right now. As Meg said, we're using eConsult as the entry into that. So if they're an in-season athlete, we're trying our best to see them within a couple days to a week, to do our best if we can to clear them. So just for your awareness that that's coming soon. And then the last slide is really just research. It's prospective research. I had mentioned that we don't really have a registry in the United States. So we don't know the incidence of sudden cardiac arrest. We don't actually know the denominator, how many kids are playing. The NCAA does a pretty good job of that, but that's a higher level sport than our youth athletes. So I think that is my last slide. I apologize for being underwater. We tested all of this, but we're more than happy to answer questions either in the chat, or if we're able to have you come off mute, we're happy to do so. So again, thank you. And I apologize for coming and leaving and all the other interference.
Yeah, so thanks, Jack. I think let's go to the chat first. So, what proportion of sports physicals are provided by physicians versus what proportion are administered by high volume schools? Jack, do you have an idea? I don't actually know.
Yeah, I don't think in the state of Washington there are that many schools that do that. At least the Seattle public schools don't. So I came off video as a suggestion of somebody in the chat. Hopefully that'll work. But you know, when we do the nick of time, it's actually not a sports clearance, it's really a sports screen. So I don't know that I have a specific answer to that, but it's not districts doing it.
Do you, at the nick of time, sign any of the PPEs?
We do not. We actually do a sport, sort of a risk assessment, but we do not sign PPEs for clearance for sports. And that's also comes up quite a bit. And hopefully this is all right with you all. But you know, when a kid comes and sees us with their PPE, we sign off on the cardiac specific, and then you all hopefully will sign off on what's relevant in the rest of it. And that's what I tell families. So hopefully that's okay.
Let's see what else we have in here. That's it from the chat. Are there any other questions that anybody want to come off mute? Otherwise, I have a few questions that I would love to, again, I'm a general cardiologist and I would love to kind of take, these are actually recent referrals that I've seen in clinic that I thought I would get Jack's opinion on.
Larnie Darvin, I think I've unmuted you.
Yes, thank you. First of all, thank you, Dr. Vernon and Salerno, for this wonderful conference. Now, I have some questions. One is, you mentioned something about, like babies who had been in vitro, don't know the donor. My dilemma is part of it, but I didn't really. Most of my IB8 babies know they came from their mom and dad, but my biological mom and dad. But what about those who are in foster care, don't know who the history, or those that are adopted, don't know what's the family history is? What are we going to look for?
So I think that, thank you. That's a great question. And I don't know that I look for anything different. It's definitely a frequent, it's something I see with some frequency where the family history is incomplete. And I think that that's actually a limitation to the PPE, that you use it as complete as you possibly can. But if you don't know a family history, then you have to recognize that part is going to be incomplete. I don't know, Jack, if you think about it in a different way.
No, I think about it similarly. When you think about cascade screening, a lot of kids come to see us because of a family history. But you know, when they are seeing us, if they don't have that family history, we do our best with the information. It looks like there's actually quite a few gymnasium sports physical exams that are listed here. And you know, having listened in a gymnasium, it's not easy if your auscultation is part of it. So I see that that's present. I don't think that's the ideal place to do it. Plus, kids are typically cold, which impacts a lot of different aspects of it. So I see that written there. So I appreciate the clarification. And I don't know that that's the best way to do that.
Thank you. Thank you very much. I live in the Tri-City area, so we have limited peds cardiologists around. We only have one on-site peds cardiology. And you mentioned something about the, what is that? Like where you go to school or something, and you teach them how to do CPR, AD, and everything to coaches, athletes, and families. But we don't have that kind of resources here.
Yeah, the part of that work is through the nick of time, and we have done both Central and Eastern Washington sports screens. So that's been throughout the state. The WIA, actually, if your schools are part of the WIA, there is the training that happens through them as well. So there are resources. I understand rural resources are tougher, and that's in part why the American Heart Association hasn't completely endorsed ECGs, because there are kids who live in rural areas that can't get the subspecialty care that kids who live closer. Now, having said that, it's not that easy to get into our clinics anyway if you're closer. So I think the time delay may be equivalent.
Okay. Well, thank you. I don't know you're doing it in here too.
Yeah, there's a question from Christina Lindell that I believe I understand, but let me just make sure. It's about that the schools. She's a pediatrician in Kent, and it says in the schools in her area they no longer require the history page of the sports paperwork. And then and I believe, Jack, I believe that's actually the recommendation. So the requirements are that you have the pediatrician fills out all the forms, but the only part you send to the school is whether the kid is restricted or not restricted. You don't send the vitals, you don't send the physical exam, you don't send any of that anymore. And I believe that's actually for patient privacy. Is that correct, Jack?
Well, I guess I'm reading a little bit different. Like, why would they not be? So, if you're doing an ECG, people will debate whether the personal history is important or relevant. But in the absence of an ECG, the only way that you can know whether there's a problem is the history question page. And being on the WIA, I'm curious if those are WIA schools or schools that are not part of the WIA, because the expectation would be that you are doing.
Yeah.
Oh, I see that the HIPAA. That's interesting to me. I don't know.
I think it's the third page because the new they say only return this. I think it's the third page. So I think the schools are following the recommendations because you don't. It was most of the schools. It seemed like that changed between around 2019 or so 1920. Like it was kind of maybe it was a little bit later actually, because it was around COVID that suddenly my kids no longer had to send the whole form back. They only had to take the signature part back to school. And I believe that was for kind of privacy and for kids, but I'm not positive.
The chat I agree with. Like they do need to do the history, and the history is most beneficial when it's the kid and the parent together. I mean, that's the most powerful. When history has a chance, it's that combination that makes a difference. And that's the first question I ask when I'm at the nick of time is, did you fill this out with your parent? It's an interesting question about advocating for mass sports physicals. I think one way to look at that though is what are the resources in that region, and how do the kids access those resources? We actually have a WIA meeting tomorrow at noon, and so I'm happy to ask about sort of the stance on mass screening, and then ask the question about the personal history. I'm writing that down now. This is why these are helpful, because we get feedback from people doing the work. So thank you.
Yeah, we definitely, it's really appreciated. I'm looking at this last, let's see.
It should be updated every 2 years, is typically. So upon entry to middle school, high school, and then the histories every year. You had it listed there, Meg, and then the exam is every 2.
Mm-hmm. Yeah, that's the recommendation, but I can only speak to the implementation that I've seen for my own kids. So I think it seems like the chat is quieting down. We've got a couple minutes. Would you be willing to, Jack, if I show you a few ECGs, kind of talk everyone through your approach?
Sure. Is this the ask the expert or chump?
Yeah.
Stump the chump.
Yeah.
Stump the
Stump
chump.
the chump. Let's do it.
Before you
Okay.
start,
Yeah.
just let me ask, Larnie, do you have one more question? I don't know if I missed, like I know you had a second one and I might not have saw your hand go up. Or did you?
No, just something that my son told me. He was in second year college in WSU. He was working in a bank as a part-time. Somebody just collapsed in front of him. And so they were able to do the CPR, although I don't know how good they are in doing it. I asked him, how come you did not use the AED? He told me, I don't know where it is. and they had an orientation and everything.
Right.
So the patient eventually, of course, 911 came, but it took a little bit of time, and the patient passed away. He was so devastated. He said, I can't sleep, mom, because I just saw a person who was in front of me and suddenly he's dead and he passed away. That was so sad. I felt very bad for him. But luckily, I told him when he was in high school, you attend the CPR that was being given by Cadlec. And he did attend,
That's good.
but the AED wasn't there. That's all. Thank you very
Yeah,
much.
thank you.
Oh, it's tough.
You.
Sorry, I'm sorry to hear that.
Okay, so I'm going to move forward here. Okay, so this first ECG, the scenario for this one, Jack, is this is an in-season 17-year-old. He is a rower and he's coming in for palpitations. And this is his ECG. Is there
All right.
anything concerning to you at all? Or should I
Yeah.
tell you more?
Well, you can tell me more, but the ECG certainly shows Wolff Parkinson White, which with the history of palpitation certainly is even more supportive of that diagnosis. And I saw 3 kids today with Wolff Parkinson White. The residents probably think it's the most common diagnosis in the region, but it is actually only 1 in 1,000, except in my clinic where you see 3. And I think over the course of my career, this has changed the most. So essentially what is shown here is an accessory pathway that conducts from the atrium to the ventricle, bypassing the AV node, which gives you that funny appearance. It also puts you at risk of sudden cardiac arrest if you go into atrial fibrillation and have rapid conduction. And so this has truly changed in the 20 years that I've done this. From if you have symptoms, we need to do something to how rapid does that pathway conduct, and we would do exercise tests and Holters to see if the pathway would stop conducting. Presumably, to have sudden cardiac arrest, you have to go 200. The pathway has to go 250 beats per minute. If during exercise, which usually your maximum heart rate is about 200, it goes away, we would in those circumstances say, you know what, it's not a high risk pathway for sudden cardiac arrest. Then about 2 to 3 years ago, not my favorite type of study, but a retrospective study did show that kids had a higher risk of sudden cardiac arrest than adults. And as a result of that, we became a little bit more aggressive on kids, particularly teenage boys with Wolff Parkinson White. And so now the majority of them undergo an electrophysiology study with the intent to ablate or to get rid of the extra pathway. And this is a good example. And this kid has palpitations. And so an ECG was done for that and showed WBW. But this is a good example of how ECG screening in an asymptomatic kid may pick this up. And I always look at it as a curable cause of sudden cardiac arrest or sudden cardiac death. So just by math, it's 1 in 1,000 will have WBW, and then presumably 1 in 1,000 will have a risk of sudden cardiac arrest. So most of these kids go to the cath lab for an ablation or EP lab for an ablation.
And I think the reason I wanted to bring this up, thank you so much. That was perfect, Jack. For all of you, again, frontline providers who are obtaining screening ECGs, hearing about palpitations, this is a perfect e-consult for us because you can send us this ECG and we can tell you what the plan is. We can get this kid in rather than a 3-month wait. We can get this athlete in because in the majority of these kids, if they're asymptomatic, we're going to let them continue with their sport, but we're going to, as Jacka mentioned, ablate this pathway. So it's a great kid to not get there in the psychological way of restricting them, but also reassure them we're going to get them back in as quickly as we can.
And there's some chat comments on energy drinks.
Oh,
and
gosh.
my sons who take 250 milligrams of caffeine before their workout. Up until recently, the caffeine, to the degree that kids took it, wasn't really that problematic. In fact, kids who have SVT, sometimes caffeine makes their SVT less likely to happen, just because it makes the circuit for the SVT less stable. But there's pretty good evidence that some of these energy drinks, particularly those that we don't really know what's in them, are problematic for our kids with either known or unknown heart disease.
100% agree. And again, as a general
There's
cardiologist,
also a comment, I'm sorry, on ECG interpretation by computers.
Ooh.
Yes, there is artificial intelligence. The ECG machine is reasonable at things like access and hypertrophy. It's less good at things like WBW and definitely not good at QTC. So when I teach residents and fellows about ECGs, you can rely on access and hypertrophy, but you always need to look for WPW, and you really do need to measure the QTC. And the best way to do that is to teach the tangent. So you just take a piece of paper, you draw a line on the steepest slope of the T wave, you look where it intersects, and you measure the QTC. So those are two things. So the AI though, it's still a machine. Part of the problem is just the biophysics of the QRS is very sharp, but large change in voltage over change in time. So it knows the QRS, just doesn't know when the T wave ends. And so it's inaccurate.
Did you see Dr. Burlingame's question? If they have an EKG and a high proportion of patients in their clinic with adoption, how routine should the use of EKG be?
I think that's an important question. I mean, I admit I have bias. I'm a proponent of an EKG, and if they have the ability to be seen and follow up if the ECG is abnormal, I think it makes sense. I think it would, is it only for athletes? I mean, that's where I focus most of my attention. I don't know if it's just generally do an EKG on everybody, but I do think in the kids where you don't have a family history and they don't have any symptoms, it might be reasonable.
Yeah, that's a great question. Oh, let's go forward. Oh, maybe let's go. There we go. Let's come up with another one. So this is an asymptomatic 10-year-old who at their exam, highly athletic, no symptoms at all. And when the pediatrician was listening to the patient, they noticed that his heart rate was irregular. And this is what they got when they did their in-office ECG. Jack, the question for this is, so for people who are, some people would probably notice this is a PVC, but the question is, when you see something like this, should they restrict and refer to us, or should we just refer? Do you have any thoughts on PVCs, PACs, irregular rhythms, things like that when you're listening? Asymptomatic.
Yeah, perfect. I think the first thing is respiratory sinus arrhythmia comes to mind when I hear an irregular heart rate. This one will be a dramatic change in cadence. The sinus rate is pretty regular in between. But those 6, 8, 9, 10-year-olds that you've ever listened to have tremendous respiratory sinus arrhythmia. When I think about premature ventricular contractions, interestingly, when the kid's asymptomatic and it's heard on an exam and they come see me, the likelihood of them having a problem is pretty small. In fact, as part of this international criteria, I'm, for better or worse, giving the talk on PVCs. And so when we see 2 PVCs on an ECG, as is indicated here, that's typically one that we want to see for evaluation, in part because PVCs, as you can imagine, the concern would be ventricular tachycardia if you start stacking them. But there's also, because the PVC is an irregular activation of the ventricle, there are kids who develop cardiomyopathy or heart muscle weakness because of the abnormal activation. It's typically when you get to about 20% PVCs. So I try to make PVCs normal. When I look at this electrocardiogram, if you get into like the nuances of ECG, which I love, this is a left bundle inferior axis. This is a pretty common RV outflow. And so if I looked at this and the kid was asymptomatic and you talk to me, I might not restrict them with a conversation. As far as the criteria that we're developing, 2 abnormal PVCs like this would then result in an echocardiogram and likely a exercise test or a Holter monitor. So people try to make PVCs worrisome. In most cases, particularly in an asymptomatic kid that just has an abnormal rhythm, it's not going to amount to much. But there's another perfect example of connecting with us and letting us try to see the kid sooner.
And then the final one, I think we all get very nervous about things we might miss. And is there anything on this? This is a screening ECG of a teenager, but it's one that, or there's something about this ECG that you don't want us to miss.
Yeah, this has pretty abnormal T waves. So usually the T waves are upright in V4, V5, and V6. It kind of is age dependent whether V2, V1, 2, and 3 are upright. But when you start looking at V4, 5, and 6, there really are no kids who should have T wave inversion in the lateral leads and inferior leads. So I start to think about heart muscle problems with this electrocardiogram. Non-funny T waves, you could start to think about long QT, but the QT doesn't look abnormal to me. It really looks like T wave inversion in the lateral leads. And I would, even without a lot of voltages, I would start thinking about a heart muscle problem, either a cardiomyopathy or others. Are there answers to these?
Oh, this is a hypertrophic cardiomyopathy. So you answered it beautifully, Jack. Excellent.
And again, this is an asymptomatic kid that you wouldn't know if you didn't have family history or the electrocardiogram. So we're not here to promote electrocardiograms. I think in some ways we're just here to show you the value of it.
Yeah. And things, if you happen to get one that you don't want to miss, you don't want to miss these left-sided. So V4, V5, V6, these guys should always be upright this way. So it looks like we're about at 7:01.
One last question. Someone asked why
There's a
the
question.
EKG was ordered for this patient.
This was a normal kid who's a pediatrician for their or it wasn't a pediatrician actually, that their standard is they get an ECG for their high school athletes that are participating in sports.
And
So
I was going to ask when someone sends in an e-consult for an EKG, I mean, I know it's typically like we have within 3 days, but I was just curious how it's looking right now for the Heart Center to respond back.
it's just a couple days, exactly the way. Yeah, we're meeting goals.
Okay.
And those are, and that's, these are great questions about, if you have an automated read and it says something, get in touch with us. We're happy to help. And we really don't want kids to be restricted. We Jack and I can go on and on about kids. I saw a kid last winter who was restricted by the time I saw him, he had been restricted for an entire basketball season for sinus arrhythmia. So we want to minimize that as much as we possibly can. So please reach out to us.
And one thing to consider when, I have different hats for when I'm reading ECGs, right? So if I'm the hospital ECG reader of the day, I'm going to read small abnormalities, left atrial enlargement. If I'm reading for a sports cardiology EKG, we only call things that really are associated with sudden cardiac arrest, heart disease. We leave a lot of those small minor abnormalities out. So I always have to be mindful of what role am I playing? What eyes am I using to read this? So just so you think, if we said, just send it in and we read it, that false positive rate is going to be 10 to 15% for athletes. If you send it in and say, hey, this is an athlete, read it with that narrow focus, that's where the false positive rate goes down to 1 to 2%. So, that's one of those things to consider. Yeah, I love the Valsalva, and it seems to be that people are not fans of doing mass screenings. I will bring that up with the WIA tomorrow. Trying to get a kid to Valsalva is one of my favorite things to do in clinic, honestly. It's not easy sometimes. They overthink everything. Are there other questions? Oh, when I actually asked them to, so I asked them to Valsalva at the end. I find with the littler kids, honestly, having them do a sit-up and not letting them sit up is probably, just sort of resisting them. I would usually tell the parents sort of what I'm going to do. But I think for me, laying down with the hand grasp maneuver, where they grasp their hands and they pull really tight and we get a good practice one in, and then I have to do another one and release. I think those are the easiest ones for me, because squatting to stand and all that, I find super hard to maintain my stethoscope and position. So I just have them laying back pull on their arms, generate increased thoracic pressure, decrease the IVC return, which will accentuate a murmur. So that's what I've done. Yep, exactly. Looks like they're.
Yeah, there's no more hands, no more questions. So yeah, are you guys, did you get everything shared that you needed to? Dr. Vernon and Dr. Salerno?
I think I did.
So. I don't know how much I shared since my audio was terrible. Sorry again for all of that.
No, that was very minimal, actually. You did a great job getting that solved. I was worried for a second. But anyway, thank you everyone for joining us. We will be sending a recap with all the resources and the recording once we get it. And feel free to reach out to any of your physician liaisons because we're happy to help get any questions answered. And also I did put the evaluation link in the chat. So we would love to hear your feedback. And thank you again, everyone. Thank you, Dr. Salerno and Dr. Vernon as well.
Thank you.
Thank you all.
Right,
Thanks very much,
bye.
everybody.